Hi everyone, this is Lauren Egan for discussion one. Um, for this week's discussion, I think it's really important for all nurses to have a really good understanding of at least the basics of pharmacodynamics, pharmacokinetics, and pharmacogenetics. This is important because we are the actual ones that are administering these medications. We're the ones that are seeing the patients, even more so than the doctors sometimes. Actually, usually. So I think it's really important for us to have a general understanding of why we are giving these medicines and how they're going to work for our patient. This is important because we are seeing these patients, and what if they've had a change since the doctors ordered the medication? So, if it's an antihypertensive and the patient's blood pressure has decreased on its own, are we still going to give this medication, especially if it's an IV medicine? This is how, we work through pharmacodynamics to best care for our patients. And a lot of nurses do this anyway. They know that, we're watching the blood pressure to call the doctor if the blood pressure is too low, even sometimes without a written order. So, we do it anyway, but may not exactly know what to call it sometimes. Um, my personal example of a time when I didn't have the best understanding of the pharmacodynamics of a medication. I was a brand new ER nurse, and we had a patient with hyperkalemia, and we were giving insulin IV, which I had never heard of before, insulin IV with D50, and I thought, I have no idea why we're doing this. Must be ordered incorrectly. So I went to the physician. Luckily, in the emergency department, as a general rule, your physician is nearby. So, I waited and went to the physician and questioned the order. And luckily, it was a very nice physician who was more than happy to explain the course of action for these medications and why we were giving them. Obviously, come to find out, we were using the insulin for active transport of the potassium across the cell membrane, giving the K-exolate for the potassium excretion, and the D50 to prevent hypoglycemia. So, I was fascinated by this process and started researching it just to learn a little bit more on my own. And according to the receptor theory in our class, it spells it out just like our text does. That the active transport of the potassium across the cell membrane, and exactly how the cells excrete the potassium with the K-exolate, and eventually brings down the potassium of the patient. So, I had heard of PT waves before, and I knew to watch out for that for the hyperkalemia as a paramedic before. Um, you know, we gave fluids for that, but I had no idea how we actually, in the long run, were going to get the potassium out. This was the first time I had kind of come in contact with that. So, luckily, I didn't just go ahead and assume that it was an incorrect order and give the insulin sub-Q. Um, and that's another instance of why we check and double check our orders. And, if I had have understood why we were doing it, I never would have questioned the order. Again, thank goodness it was a polite doctor that didn't say, why didn't you just look it up yourself? But, it was very interesting to learn how these three medications in conjunction with each other were going to bring down the potassium for this patient. Um, Thirdly, the pharmacogenetics I think is so interesting, and one way that I think emergency medicine has come a long way is pharmacogenetics helps us understand that some patients may not react to drugs or may have, there's certain diseases that certain races of populations have that others don't. So we see a lot of sickle cell crisis in the emergency department. Um, you know, Years ago, you may have had folks that are coming in complaining of back pain or knee pain. A lot of times sickle cell crisis patients have a lot of joint pain, or they might have chest pain. So, um, they may have just given them some Motrin and sent them on their way, and couldn't figure out why they kept returning and returning, until they actually, we know that we do the blood test, for the African American population, and we check to see if their red blood cells are sickled or not. So I think that's just one instance of pharmacogenetics that, everything is not the same across the board for every patient population, and that's why testing is so important, for all of these patients, and continuing to watch patients and, make sure that the medications are working for them, doing assessments and reassessments consistently, to make sure that the medications are doing what they're supposed to for the patient and not having any adverse reactions. So I'm very excited about this class and look forward to our next discussion. Thank you.